Hi, my name is Paul Offit. I'm talking to you today from the Vaccine Education Center at the Children's Hospital of Philadelphia. One question that parents reasonably ask is it possible that vaccines could cause autoimmune diseases or chronic diseases? And by autoimmune disease, I mean a disease where the body reacts against itself. Now, it's certainly true that certain viruses or bacteria can cause autoimmune diseases. So, for example, Lyme disease is caused by a bacteria. When you're infected with that bacteria, you generally rid yourself of it, but it can cause chronic or long-term arthritis, meaning inflammation of the joints. Because when the body reacts to the bacteria, it's also reacting against itself, essentially reacting against its joints. Similarly, strep throat can set up for rheumatic fever. So while you're reacting to the bacteria that causes strep throat, you're also reacting to the lining of your own heart that can cause symptoms and signs of rheumatic fever. So we know that bacteria can do it. We know that viruses can do it. The question is, can vaccines do it? Now, there are a few examples that I think help to answer that question. One is that there was a Lyme vaccine. It was used in the United States between 1998 and 2002. And while it was clear that Lyme bacteria could cause chronic or long-term arthritis, the Lyme vaccine couldn't do it because it didn't have what it took to drive the immune response to cause autoimmunity. Similarly, if you look at people who have multiple sclerosis, when they're infected with natural or so-called wild-type influenza virus, they have a worsening of their multiple sclerosis. That's clear. However, when they're given the vaccine, they don't have that. So again, in many ways, then the influenza vaccine prevents the exacerbations or worsening of multiple sclerosis in someone who has multiple sclerosis. Now, there are a couple of very rare examples where a vaccine could cause autoimmunity, or said another way, the vaccine could cause the body to react against itself. One is influenza virus. It is possible that roughly 1 per million people who get an influenza vaccine can have a disease called Guillain-Barré syndrome, where the body essentially reacts against itself and causes this sort of ascending paralysis. It starts at the legs and then works its way up the body and can affect breathing. Now, of interest, influenza virus, the natural virus, also causes Guillain-Barré syndrome at a rate roughly 17 times greater than that's caused by the vaccine. Or said another way then, the influenza vaccine then arguably prevents Guillain-Barré syndrome. There's one other isolated example where a vaccine could cause autoimmune disease. It occurred in Europe. It occurred in 2009. It was associated with a squalene adjuvanted influenza vaccine called Pandemrix. Now, the rate of narcolepsy, which is a permanent disease of wakefulness that was caused by that vaccine, was, depending on the country you looked at, between 1 in 15,000 to 1 in 50,000. We never used that vaccine in this country, the United States. It was never used again, and so I don't think that's ever going to be a problem again. So I think that we can feel comfortable that for all the diseases that are associated with autoimmunity, and frankly for all the diseases that are just sort of chronic diseases that are not associated with autoimmunity, there have been study after study after study showing that vaccines don't do that. And vaccines really, frankly, are the safest, best tested things we put in our bodies, because once they're licensed, regulatory agencies and academic institutions look very hard to see whether it's at all possible that vaccines are doing more harm than good, that vaccines might be causing autoimmune or chronic diseases, and clearly and consistently that's been shown not to be true, with the exception of the couple rare instances I mentioned. So again, vaccines are safe and effective, and a choice not to get them is not a risk-free choice. It's just a choice to take a different and more serious risk. Thank you.
A new study found nearly 1/3 of people surveyed say they will not get the COVID vaccine. Researchers interviewed nearly 5,000 Americans. Those who do not intend to receive the vaccine say they're concerned about the safety and effectiveness. Others cited the cost or lack of health insurance. Women, African Americans, and conservatives were the most hesitant about the vaccination. We've been hearing a lot of questions from people with autoimmune diseases about whether or not the COVID-19 vaccine is right for them. Every day for the last few weeks, NBC 10 Responds has taken your questions, Write to leading doctors to get you answers. Today's first question comes from Miles. Is it safe to receive the COVID vaccine if you suffer from multiple sclerosis? Well, when I asked Dr. Shafinaz Akhtar from Chester County Hospital about this, she said her answer is for anyone with any autoimmune disease like Crohn's disease, lupus, or rheumatoid arthritis.
And our advice has always been that there is really no harm to getting it. All right, so it's very unlikely that you're going to have immune activation, worsening disease, worsening symptoms from your underlying disease based upon receiving the vaccination alone.
Dr. Akhtar says that most people with these diseases are on immune modulating therapy, which could suppress the ability of the vaccine to mount an immune response. She suggests that you talk to your healthcare provider about the timing of your vaccine along with your medications. Next question comes from Sandy, who writes, if you still have symptoms months later, no smell, no taste, should you still get the vaccine? Well, Dr. Akhtar told me that the natural infection gives you a natural immunity for 3 months, probably longer. So it's safe to defer getting the vaccine if you've had COVID-19 in the last 3 months.
There's a lot of data that's coming out that may suggest that you can be reinfected within at least, after at least 6 months. And that in all likelihood, vaccine may actually give you better immunity than natural infection, remarkably.
Now, if you have a question about the COVID-19 vaccine, we will get you the answer. Just email us to vaccine@nbcphiladelphia.com
Every
or
week,
write to us on
Delphine
our
comes
NBC
here for
Philadelphia
chemotherapy.
Facebook page.
But as well as living with cancer, she now lives in fear of COVID. The risk of contracting a severe form of the illness means she's had to make major changes to the way she and her 7-year-old daughter interact socially.
On a peur mutuellement, autant elle de me donner le virus et vice-versa. Donc on ne voit pas beaucoup de monde. Par exemple, d'aller voir mes collègues de travail, aller boire un café avec elles, ça me manque énormément de retourner dans mon établissement. Et c'est vrai que là, je me l'interdis. Le vaccin, c'est un espoir. Et c'est surtout pour nous protéger, nous, et l'entourage. Et puis revivre, quoi.
It took more than a month of negotiations for health authorities to give the green light to doctors demanding the vaccination for cancer patients. In the Sainte Catherine Institute in Avignon in the south of France, medics are making sure the process is properly supervised and patients' treatments adapted.
C'est ça qu'on vous propose de faire. Vous avez une analyse faite à la maison, je la récupère, je regarde et je vous dis vous êtes plus protégé, c'est bon, et il faut simplement resurveiller le taux d'anticorps après. Et si jamais votre taux baissait, ça peut être une 3e vaccination, une 3e injection derrière, ce que n'ont pas prévu pour l'instant les pouvoirs publics encore.
But doctors say they can't guarantee results, estimating the effectiveness of the vaccine on cancer patients at just 30%.
Ce qu'on ne sait pas, c'est est-ce que le vaccin va être efficace, par exemple, chez un patient qui est en cours de chimiothérapie. Il se peut que le vaccin ne fonctionne pas parce que l'immunité en cours de chimiothérapie est altérée. Les mécanismes qui font l'activation de l'immunité contre le virus peuvent être altérés. C'est surtout ça la zone d'ombre.
The Pfizer and Moderna jabs claim 95% effectiveness, but clinical trials didn't focus on immunocompromised patients. Despite the uncertainty, the Sainte Catherine Institute has been told it will get the vaccines it needs. The campaign here is set to last several months, with 20 to 40 patients injected per day.
There are no half measures.
Let me talk you through the PPE process.
Not just one set of overshoes, but 2. Disposable overalls, 1 pair of gloves under it, and another over the top. This is a level 3 containment lab, airlocked and ultra clean. One of only a handful of labs in the country working with the new, more infectious variants of the SARS-CoV-2 virus.
So here we are just looking at cells that were not infected.
Under the microscope, just look at how healthy cells, like those in our lungs, are destroyed by the infection. Oh my goodness.
Here we can see that most of the cells are dying because of the infection of SARS-2.
It's painstaking research, but there's a sense of urgency too. We need to understand why these viruses are more infectious and more immediately when our vaccines work against them.
And that's exactly what they're doing in this high containment lab. These experiments were essential if we're going to understand what the viruses are capable of doing outside the laboratory.
Can they be transmitted better? Can they have a different clinical outcome? And more importantly, given this phase, can they escape the current vaccination rollout?
Here in Glasgow, they're currently looking at the new UK variant. Early indications are that while it might be able to escape the immune system response produced by our vaccines, it's unlikely to prevent them from working altogether. There's far more concern about new variants circulating in Brazil and South Africa, and here's why. This is the spike protein on the surface of the virus that helps it invade cells. The UK variant has a mutation here, thought to enhance that ability. But the other two strains have two additional mutations that may help them avoid the immune system.
So we have this alarming data, and it's certainly alarming, but we don't have all the parts of the jigsaw puzzle to be able to translate that into what it means for reinfection, which is the other major issue, and what it means for vaccines.
Professor Moore has just completed lab experiments suggesting the variant in South Africa can entirely escape the immune response in some people previously infected with COVID. But only data from trials like this one in Soweto will confirm whether vaccines will work or not.
Do you think it's inevitable that we're going to end up making new vaccines to more specifically target these new variants that are emerging?
I think it's as close to inevitable as, yes, I think it's very likely. Having said that though, the data that we don't have yet are really from the vaccine trials, and that's the most reliable data that we have. So if we see an uptick in infections with these new variant strains in people who've been vaccinated, that would be the final answer on that question.
Those designing new vaccines need research like this to define what alternatives should look like. While they don't know everything yet, they're closing in on the answers. Tom Clark, News at 10, Glasgow.